Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LERRN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LERRN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Good morning or good afternoon, wherever you may be. Welcome to this LERRN online symposium entitled The Promise of Drug Therapy to Reverse and Prevent Lymphedema. As many of you know, I serve as the chair of the Scientific and Medical Advisory Committee of LERRN, and I'm also a professor at Stanford University and one of the co-founders of LERRN. So the context of today's talk is going to be the fact that we are about to launch a new clinical trial at Stanford related to the reversal of lymphedema. And so today's symposium is intended to give you some of the background of the 20 to 30 year scientific journey that I've been on to come to the launch of this new clinical trial. And for those of you that are interested in the pragmatics of the trial, what it means to be in a clinical trial or potentially to participate in the clinical trial, we will have a follow-up symposium in 2 weeks, which you are, of course, welcome to attend, and that will be much more oriented toward the trial itself. I do want to say just a word of housekeeping before we begin. I'm going to try to save some time for question and answer at the end of this webinar. Please do put your questions in the Q&A box within the Zoom functionality and not within the chat, and I will try to get to as many of those relevant questions as I can at the end. I want to thank the sponsors for this series, who you see listed on the slide here. These are all companies that have a wonderful relationship with LERRN and that help us to do much of the good work that we're able to do. I do want you to be aware of this disclaimer that this information is provided for you to be consulted with your healthcare professional, and we're not trying to take the place of your physicians and healthcare providers. So to begin this topic, let me say that when I launched into this realm of research in the early 2000s, it was my belief that we should be able to find medical therapies for lymphedema. We treat most chronic conditions in adult medicine with medications, and those medications are meant to stabilize and potentially reverse or potentially prevent these diseases. And when I entered this field, and to this day, we really have not had this option of using drug therapy in any realistic way for lymphedema. Now, part of the problem was when I entered the field, and to this day, it still is the case that many people believe this misconception that the lymphatics are the sewer system of the body. That's not correct, in my opinion. But one of the problems with that thought process is that we can't really rebuild the sewer system. So if we are to deal with this concept, then we are basically saying that the progression of lymphedema is inevitable. And I really don't believe that that is the case. Now, when lymphedema begins, it begins like all edema conditions, which is that there is an accumulation of fluid within the tissues. And in medical terms, we call this a pitting edema, which means that the physician, when examining the patient, can move the fluid by simply creating external pressure. And here you see what has happened after I've placed my finger firmly on the skin for 30 seconds. I've moved the fluid away to a different portion of the tissues, like the parting of the Red Sea. This is a very favorable finding in early lymphedema because it means that the physical therapist is going to be able to use similar modalities to actually clear the fluid from the involved arm or leg and bring the limb to a smaller size. The problem with lymphedema and the problem with the physical management of lymphedema is that pretty inevitably we get to a stage where that pitting quality is lost, and it is lost for the simple reason that the body responds to the chronic edema by changing the physical attributes of the tissues. The cells grow in number, they grow in size. There is deposition of fatty tissue under the skin. There is the deposition of scar tissue, or what we call collagen or fibrosis. And all of this serves to increase the limb in a way that cannot be massaged, it cannot be compressed. It basically is what we have historically called the irreversible phase of lymphedema. Well, it turns out, based on my research at least, that it's not irreversible, and it is actually a candidate for drug therapy. And even in cases where this physical change becomes very far advanced, this is stage 3 lymphedema, even in settings like this, we've been able to see in our human application of these drug therapies that there is reversibility to this disease condition. So I think it is a very promising area of development, of research, and future clinical practice. We have to acknowledge that the lymphatics are not simply a sewer system. They're a very complex part of only in the management of fluid distribution within the body, but also in their role within the immune system and the immune function of the body, which is really the interface at which the drug therapy is able to achieve its endpoint. So let's talk about developing a drug to reverse and prevent lymphedema. And of course, I'm sure many of you are aware that in order to make advances in human medicine, we have to rely upon research in animals. And in my case, the use of a mouse model for lymphedema has been critical to finding what we have been able to discover. The mouse, of course, is very different than the human, but many of its attributes are shared by human biology and human pathology, which allows us to make important discoveries. So back, as I said, in the early years of this millennium, I developed an animal model to study lymphedema. And what we decided to do is use the mouse tail as a kind of model for a human limb, an arm or a leg. And by dealing with the lymphatics that run through the length of the tail and destroying them in much the way that many patients have destruction of lymphatic structures by cancer therapies and other issues, we are able to create a chronic edema in the tail of the mouse that resembles the chronic edema that we see in an arm or a leg, for example, of a cancer survivor. And the beauty of this model is that not only can we study the tissues under the microscope and study them in molecular terms, but we're actually able to measure the changes in the volumes of the tail by simply taking photographs of the tail and using certain mathematical derivations to very accurately determine volume and volume changes in relationship to treatment. So what we see in the mouse tail is that when we look at the skin under the microscope, and remember, the skin is the part of the body that is damaged when lymphedema supervenes, you can see that in comparison to the normal skin, this is the cartilage at the core of the tail, and then all of this is the skin. You can see that in the presence of lymphedema, the skin becomes so thickened that we can't even fit the core of collagen on the slide. It is tremendously increased in thickness, in cellular mass. There's a lot of inflammation. There's dilation of lymphatics. This is very, very abnormal and very different than what we think the normal looks like. And when we do specific staining under the microscope, we can see that, in fact, the lymphatics, which we can directly identify, are dramatically dilated because they're full of this fluid that cannot get into the draining channels and leave the tissues, which is why the edema is occurring. So with that background, what I decided to do at the very outset is to say, look, we're probably not going to be able to rebuild the sewer system or whatever we want to call it why don't we figure out what is happening to the tissues that are being damaged by this disease, because that may give us targets that are reversible. And so we took the skin of the lymphedema tails and we compared it to the skin of animals where we did a simple surgery, we damaged the lymphatics. And what we looked at is the RNA expression profiles of the skin. So that is really a way of looking at the body's genetic blueprint and determining what part of the blueprint is turned on by the cells as they respond to lymphedema, because anything that's different from the control animals represents the impact of lymphedema. And what we found, much to our surprise, is that almost nothing had to do with fluid or with the circulation or with anything that we would directly attribute to the lymphatics. Almost everything that we saw was related to inflammation and to the immune response. What we were seeing, in essence, is that based on the body's blueprint, lymphedema is an inflammatory condition, which led us to believe that if we could identify the specific form of the inflammation and the specific responders to the inflammation, that we could turn off this response and perhaps change the outcome of the disease. And this led us to the notion that while lymphedema starts with an abnormal function of the lymphatics, and there is immune abnormality that is seen, and there is edema, at the end of the story, it's this part of the equation that seems to be the most active part of the disease, and that is the potential target for treatment. And as we delved into this very intricate molecular analysis, we found something very interesting, which is that there was upregulation of an unexpected inflammatory pathway that is initiated by the action of an enzyme called 5-LO, or 5-lipoxygenase. And while this enzymatic pathway is very well recognized to be active in other forms of disease, like asthma, for example, it really hadn't been described to any degree within the skin. And we found this was very interesting. So we decided to say, well, why don't we try blocking the activity of that enzyme pathway to see what happens to the lymphedema mouse? We had access to a prescription drug that blocked this pathway and also another inflammatory pathway called cyclooxygenase. And you are familiar with this pathway because all of the over-the-counter pain relievers and anti-inflammatory agents that you can buy in your neighborhood drugstore typically block this pathway. So that would be Advil, Aleve, Motrin, all of those drugs, which I hasten to say do not work in lymphedema. So don't run out and go and buy those. But we used a drug that simultaneously blocked this pathway and this pathway. And what we found, much to our delight, is that when we used the drug in normal animals, we saw no change whatsoever, either on a molecular basis or by looking under the microscope. But when we used placebo in either setting of the normal tissue or the diseased tissue, again, we saw nothing to change. But when we used this drug in the setting of active lymphedema, in as little as 2 weeks, we not only saw the edema go away, but we saw a reversion of the tissue to a basically normal pattern. So what was historically called irreversible change in the tissues based on lymphedema, in fact, turned out to be reversible. So this was a very, very exciting finding. And this led us to then say, well, why don't we try this drug in patients with lymphedema? And I can tell you that over the last 2 decades, I've treated about 300 patients with various regimens related to this medication. And we've seen very dramatic responses that have continued to fuel our interest in this research. We eventually completed 2 clinical trials. They were pilot trials. They were paired together, published in this one manuscript that was initially, we used what's called open label use of the drug, meaning everybody got the drug. There was no placebo. We simply wanted to see what happened to the patients. We found that it was safe. We found that it did have a beneficial effect on edema volume, and that when we looked at the skin by biopsy, there was a dramatic improvement in the appearance of the skin. Therefore, we went on to a placebo-controlled component of this trial, and the primary endpoint of the trial was met, which was a reduction in the thickness of the skin that we could measure clinically. So what we do is we take a set of calipers and we try to pick up the smallest section of skin that we can with the caliper. Now, in a normal arm, this is an arm, a patient with breast cancer-related lymphedema, we would expect this thickness to be about 2 millimeters. This patient, prior to treatment in the open label portion of the study, had a thickness of about 35 millimeters. So basically more than 15, almost 20 times normal thickness of the skin. After treating the patient for 4 months with the drug, the thickness of her skin reduced down to almost normal. This is about 3 or 4 millimeters. So still maybe twice what it would be on the normal size, but a dramatic improvement over what was seen prior to treatment. When we looked at that in the trial overall, the patients who received the active drug did achieve that reduction in skin thickness. Those who were treated with placebo did not. We also looked at tissues under the microscope, and we were able to compare the skin on the normal arm from the skin on the lymphedema arm, and we found that there was a dramatic improvement in the appearance under the microscope. And what I want to emphasize most importantly is that we actually saw that the collagen content, which is really that scar tissue or fibrosis that we think characterizes late previously termed irreversible lymphedema, in fact, reduces under the aspect of medical therapy. We see a reduction in the overall thickness of the collagen content in the skin when we look under the microscope. So this, to me, lends tremendous promise to the notion of a favorable ability to treat this condition with drugs. We also did specific staining for that enzyme that I mentioned at the beginning, 5-LO. That's the parent molecule that is driving this bus. And we were able to show that, as we would expect, under the influence of the drug therapy, we saw a reduction in the expression of that enzyme in the skin during active treatment. So this was very encouraging. And certainly we felt that we were well on the road to something that was useful. However, there is a catch in all of this, which is that whole family of anti-inflammatory drugs, which are called NSAIDs, which includes not only the drug that we were using, the prescription drug, but also the over-the-counter drugs that I mentioned earlier, Advil, Aleve, Motrin, and so on. That whole family of drugs, shortly after we completed this clinical trial, was declared to have a problem. And there is, if you buy a box of one of these drugs and you look at the package insert, you will see that there is a black box warning from the FDA that suggests that these drugs do increase the risk of cardiovascular events, hypertension, stroke, and heart attacks. So while lymphedema is a dreadful problem that we want to solve, we don't want to trade one problem for another, and we would rather not use a drug that has this heavy set of warnings and a whole class of patients who perhaps are not candidates for the therapy because they already have existing problems. So we decided to go back to the animal model to understand a little bit better exactly what was happening in order to refine our treatment approach. So again, this is the schema that we were originally working with, and ketoprofen, the drug we were using, blocks both of these enzymes. Because the NSAID family in general involves blockade of this aspect of the cascade, we were wondering whether perhaps most or all of our treatment effect was based upon this part of the cascade, which shouldn't represent a threat for that cardiovascular aspect of things and would make us able to treat this in a much safer way. Well, it turns out that the answer is yes, it is 5-LO inhibition specifically that seems to drive the bus of reversing the aspects of lymphedema disease. And so we did a series of very, very intricate molecular studies and observational studies, which we subsequently published in a very prestigious journal, Science and Translational Medicine, to show that it is one of the downstream molecules activated by 5-LO that seems to be driving lymphedema forward, and that is the target for reversibility. Many who are listening to this webinar will have either had a lymphoscintigram or know what it is. This is what a lymphoscintigram looks like, or the equivalent of a lymphoscintigram, when we do it in the mouse tail. And what you see under the microscope is this very intricate honeycomb pattern of lymph channels that are present in the skin of the mouse tail when it is normal. This is what lymphedema looks like in the mouse tail. And by inference, this is what lymphedema would look like in the human tissues, which is that there is a complete functional disruption of this network, and the lymph tissue spills out into the tissues. The lymph fluid spills out into the tissues and forms, in essence, little puddles of lymph all through the tissues. And what we see on the outside is a swollen limb, or in the case of the mouse, a swollen tail. Well, when we used a drug that specifically blocked the downstream molecule from 5-LO, the one that we identified as being the culprit, we found that and this is a drug that we administered by injection, so it's a systemic drug. We found that in as little as 1 week, there was almost complete restoration of what we'll call the lymphoscintigram to a normal pattern, and all these puddles of fluid basically went away. So this is very concrete evidence that blocking this molecule, LTB4, actually can reverse the lymphatic flow abnormalities that are associated with lymphedema. And I want to show you a couple of very compelling images in the whole mouse, just so you can understand. Whoops, sorry. Let's see if this is going to work. Here we go. So I'm going to show you, first of all, a mouse that is treated with a placebo. This is the swollen mouse tail. We cut the lymph channels right here, and this is where the lymph flow would be going to the body of the mouse, so taking the fluid back to the mouse's heart. And you basically do not see anything happening here. I want to contrast that with what happens when we treat a lymphedema mouse with the drug. So once again, this is the swollen mouse tail. Here's where we did the surgery. And in just a moment, you're going to start to see channels of white traveling across this surgical site back to the body of the mouse. We have actually restored lymph flow from the swollen mouse tail back to the body, which allows the tail to heal and the lymphedema to resolve. Now, it turns out that not all drugs are going to do this. So we looked at a variety of compounds, including ibuprofen or Motrin. I can tell you this is what happens when you give the mouse tail Motrin. The tail gets, if anything, worse. Ketoprofen, of course, did make the mouse tail better. And as we looked at various compounds that were able to affect this pathway at various points in the chain, we learned that only the drugs that blocked 5-LO or that specifically blocked the production of LTB4, that downstream molecule, were the ones that were able to reverse the mouse lymphedema. And compellingly, we looked at the concentrations of that compound, both in the blood of the mouse, and we had some human subjects that we were able to get samples from as well. And both in mouse lymphedema and in human lymphedema, there is a fairly dramatic increase in the concentration of LTB4 that is circulating in the blood, which is evidence indirectly that this compound is in fact involved in the lymphedema mechanism, and that there is this dramatic similarity in this case between mouse lymphedema and human lymphedema that allows us to extrapolate the observations from the mouse to the human situation. So just to summarize again, we decided therefore that the cyclooxygenase component of ketoprofen, our initial miracle drug, was not as directly involved in the treatment benefit, which allowed us to get away from the concern over cardiovascular toxicity and allowed us to focus on this downstream component of our original target, which was LTB4. So just to give you an idea about what it means to have identified this specific culprit, if you have a tree in your backyard that has some kind of an infection or problem, you could come along and chop it off at the base of the tree, and what you're left with is a tree stump. And that's what it's like to block 5-LO. You're blocking everything downstream of this enzyme. This is like cutting off the branches that are no longer growing leaves. Everything else is left intact. We're just targeting the very specific problem in the tree that is making it unwell. So we're very excited to have identified this specific target. This target, a lot has been learned about LTB4, and it's a very important molecule in the body overall. We know that when LTB4 interacts with its receptor on a variety of cells, there are a variety of pathological conditions that can be affected by it. And now we need to add lymphedema to this list, specifically in the setting of lymphatic damage. So with this excitement over what we were able to learn in the mouse, we wanted to go back to the human setting again. And I was very fortunate to be able to launch a clinical trial several years ago in leg lymphedema to look at the impact of a specific antagonist of LTB4 called Ubenimex to see its impact on lymphedema. Now, the problem with this trial, and I need to explain a little bit about the biostatistics related to clinical trials so that you all will understand, is that we, in essence, had to terminate this trial for funding reasons before we could draw an absolute conclusion. So when we design a clinical trial, we talk about the power of the trial to test the hypothesis that the trial is trying to investigate. And we can, through statistical analysis, predict how many observations we need to make before we can decide that what we have observed either proves the hypothesis or disproves the hypothesis. To give you an example, if you have a drawer full of white and black socks and you want to be able to prove that there are white socks in the drawer, you might stick your hand in and the first 3 or 4 times come up with a black sock. And you might, from that observation, conclude that there are only black socks in the drawer. But if you stick your hand in enough times, you'll come up with a white sock. And so you can predict how many socks you need to pull out before you conclude that there either is or is not a white sock in the drawer. So we do something like that with clinical trials. The powering of the study that we needed to do to conclude that that this drug does or does not reverse lymphedema was to study about 250 patients randomized either to placebo or active drug. We only ended up having enough funding to study 50 patients. And so what I want to tell you is we don't know whether this trial was positive or negative, but I do want to share some tantalizing images with you. This, where are we here? This was the last patient that we enrolled in the trial. It was a double-blinded trial, so we didn't know when we were studying her whether she was receiving the active drug or the placebo, but it turned out after the fact she did receive the active drug. This is a woman who had to leave her career as a critical care nurse because she developed lymphedema in the left leg on the basis of cancer therapeutics. And you can see that there is a rather substantial lymphedema present prior to our treating this patient. This is what the leg looked like after 6 months of treatment with this LTB4 antagonist, Ubenemex. And you can see that there's virtually complete resolution of this patient's lymphedema. And this is not the sole observation that we had. Basically, the LTB4 patients got better. The problem is many of the placebo patients got better as well, based on the fact that they were being actively observed, they were actively having enforcement of their compression regimens and so on. And this blunted our ability to prove that the active drug actually did its job. But even more compellingly, I hope to all of you, is going to be the photographs that I received 18 months after the patient stopped taking the drug. So again, this was her leg prior to treatment. Here is her leg 18 months after she concluded the trial. She has gone back to school to get a master's degree. She's gone back to critical care nursing, and she requires very little compression to maintain her leg in a normal state. So this is a very exciting observation to me. It's what we call an empiric observation. We can't draw conclusions from one patient. And as I said, there were many who did respond, but we need more conclusive proof so that we can convince the FDA that this is actually a drug class that should be approved for the treatment of lymphedema. Now, there's reason for me to understand why this woman's leg potentially remained normal so long after she stopped treatment. If you stop your diabetes drug or your blood pressure drug in the middle of treatment, within 2 or 3 days, you're going to be back to where you started from. But in this case, what we learned from studying the animal model is that one of the ways that the body responds to reducing the concentration of LTB4 in the tissues when there is lymphedema is that it allows the lymphatic system to heal itself. The impact of elevated LTB4 levels when there is lymphedema is to actually block the lymphatic repair process. And what that means is that we can hope that drug therapy for lymphedema may be a time-limited intervention that actually resolves the problem. And even more importantly, in my opinion, is that it opens the door to the notion that we could preemptively treat patients at high risk for developing lymphedema and prevent the lymphedema from occurring by allowing the lymphatic repair response to occur in a timely fashion when it needs to. So, with all of this, and I'm about to conclude my comments, I'm happy to say that we are at Stanford about to launch what we hope will be a more definitive human trial of LTB4 antagonism. We have the ability to work with a drug that is even more targeted than the one we used in the abortive Ultra trial. And we now have the assurance of a sufficient amount of funding to be able to bring the trial to completion. We have powered the trial in such a way that we know we'll be able to draw a conclusion after we enroll all of the subjects that we need to study. Now, I want to explain before I conclude my remarks and open up for Q&A, I want to explain that the goal with all of this work is to come up with a drug that will be useful for all forms of lymphedema: arm, leg, cancer, non-cancer, primary, secondary. But in order to do a clinical trial that is adequately powered, we need to design the trial so that there are as few variables among the different subjects in the trial as possible, so that we can draw valid statistical conclusions from the observations that we make. I want to be sure that everybody listening understands that when we do mouse experiments, we're basically doing experiments on whole colonies of identical twins, which means they are genetically indistinguishable from one another. And the only thing that changes from subject A to subject B to subject C is what we do to them, what drug we give them, what surgery we do, what we do to perturb their normal anatomy. We don't have that luxury in human clinical study, but we can sharpen our vision optimally by having subjects be as similar to one another as possible. And for that reason, we have inclusion criteria, we have exclusion criteria, and we try to design the trial to make the view narrow so that we can then broaden it once we prove what we need to prove. So I want everybody to understand that what we have chosen to do for this study is to look at arm lymphedema for the specific reason that arm lymphedema patients are more similar to one another than our leg lymphedema patients. It means that we don't need to study as many subjects. We won't get into the same problem that we had in the ULTRA trial. This is not to say that we are more interested in arm lymphedema. It is only to say that it is the shortest path to the goal of making this drug available for everyone. But I want to conclude by saying that lymphedema is not a hopeless endpoint. It is an arena where we can offer hope. I think this line of research has brought tremendous observations, tremendous impact potentially for the future. And I'm very excited to launch this trial so that we can bring new answers for the patient community. As I mentioned at the outset, we will have a follow-up webinar in 2 weeks where I will present a lot of the specifics related to the trial and specifically for individuals who are interested in participating, the mechanisms whereby that can occur. So I'm hoping not to answer too many questions today about the specific trial, but would love to answer questions more related to what I've talked about in general today. So with that, I'm going to turn off the slides and I'm going to look at the Q&A, and I hope you'll forgive me as I need a moment to read what's written here. Somebody asked if this therapy would work on a pannus. That depends on whether the pannus is related specifically to lymphedema or is an indirect aspect of the abnormality that's present. Somebody asked if collagen supplementation is beneficial for lymphedema patients. No reason to think that that would be the case. Let's see. Can cortisone help reverse lymphedema? That's an interesting question. Cortisone, of course, is an anti-inflammatory drug. The problem is that cortisone has, like ketoprofen for that matter, both positive and negative attributes. And clinically, when we see patients who are being treated with cortisone for other reasons who happen to have lymphedema, sometimes they get better, sometimes they get a lot worse. The problem with inflammation is it is a mechanism in the body that is very targeted and has many, many moving parts. And to say that you have an inflammatory condition is a little bit like saying you have a car. That car might be a Honda, it might be a Tesla. If you have a Tesla, you're not going to take it to a Honda dealer to do service on it. And so choosing an anti-inflammatory drug means that the more targeted it is, the more likely it is to actually reverse the condition that you're looking to reverse and to cause the least number of problems. Cortisone is a remarkably untargeted form of anti-inflammatory therapy. And so I would say it's not something we would empirically choose if we were just treating lymphedema. Let's see. Somebody asked, and I'm going to answer this again. Why are human trials being restricted to people with upper versus lower extremity lymphedema? Well, the first answer is that's not a correct statement, because the two prior trials that I mentioned to you had lower extremity lymphedema subjects within them. The first trial, the ketoprofen trial, was both upper and lower. The second trial was lower. This launching trial will be upper, and I hope I explained why that is the case. It is a decision that was made on the basis of trying to get to the endpoint with the least number of subjects required to make a valid observation. Somebody asked, will the leg be back to its normal look? The answer is yes, in many cases, not all cases. Somebody asked the name of the drug. The drug we will be studying in the new trial is called acebelestat, and it is an investigational drug. We have what's called an IND from the Food and Drug Administration to study this drug in human subjects. And the goal is to give them enough information so that this drug will be able to be made clinically available to everyone. Somebody asked, how long will it be until this treatment is available? Well, unfortunately, the path to drug development is relatively long. And it takes time, and it takes enough observations to convince the FDA. I would say minimally we're looking at a 2 to 3 year time frame until this is going to be in the clinical arena. Let's see. Somebody asked, will this be US citizen trials or Europe as well? The problem with clinical trials, and we'll get into this in a couple of weeks, is you can't do clinical trials at a distance. It requires direct and frequent observations of the patients. And so, given that this is a Stanford-based clinical trial, at the moment, this study will be performed only at Stanford, and those individuals who are able to come to Stanford for the number of required visits will certainly be eligible, but we certainly can't do it in Europe, and it would be unlikely that somebody would be able to, travel back and forth from Europe. Now, in the future, there may be multi-center trials, and some of those may be Europe-based, and it may be an international trial. I can't predict that at the moment, but for now, we'll be doing a single-center trial. Somebody asked did the drug reduce volume? And the answer is yes, it can reduce volume. It does not necessarily dramatically reduce volume if there is very advanced structural change. But as you saw in the one patient I showed, her lymph volume came down basically to normal. And the second part of the question is, do I predict that lymphedema and or lipedema patients will also respond positively to drug therapy? The answer is potentially, in principle. I've not talked about my research in lipedema, but the work that I've done strongly supports the notion that I retain that lipedema is a lymphatic disorder, and therefore, if the lymphatic abnormality is responsive to LTB4 antagonism, or if the abnormality of lipedema is LTB4 related, then yes, these patients should respond. But we have no direct observations yet in lipedema. And unfortunately, as many of you may know, there is no animal model for lipedema, so we've not been able to make non-human observations yet. When the patient has so-called lymphedema or stage 4 lipedema, there is lymphedema superimposed upon the prior lipedema presentation. And at least that component of it, the lymphedema component, I would predict should respond comparably to what we see in the other forms of lymphedema. Somebody asked, how does this treatment affect those that already have existing inflammatory diseases such as osteoarthritis? Well, talking about the earlier drug that we're trying to steer away from because of its cardiovascular implications, a drug like ketoprofen, which is capitalizing on the lipooxygenase component to reduce the inflammation of lymphedema, will reduce the inflammatory manifestations of osteoarthritis through the cyclooxygenase component. So if one were to use a drug like ketoprofen in the combined presentation like that, you would get the combined benefit of both aspects of the drug. The drug that we're going to be studying in the new trial doesn't have the cyclooxygenase component, so it doesn't put people at risk for cardiovascular events, but comparably, because it lacks that aspect of its action, it may not and likely wouldn't have as much impact on an inflammatory condition like osteoarthritis. It's going to be anti-inflammatory, and we don't know yet to what degree it's going to help other inflammatory conditions. The drug has been used in aggregate in several hundred patients, human patients in a variety of clinical contexts, including a clinical trial related to COVID. It appears to be an extremely safe drug, but we have still a lot to learn about where it can be utilized effectively. We do know that it has tremendous efficacy in other inflammatory skin conditions, for example. Somebody asked, is this study only on secondary lymphedema? No, if there is arm lymphedema on the basis of primary lymphedema and it affects only the arm, yes, that individual could be included in the clinical trial as well. But again, I want to emphasize that the goal of this trial is to look at one form of lymphedema with which we can extrapolate to all forms of lymphedema. Eventually, it is my belief that LTB4 antagonism will be able to be used in primary and secondary lymphedema, in arm edema, leg edema, head and neck lymphedema, secondary, primary, cancer-related, non-cancer-related. I believe we're dealing with a very protean manifestation of lymphedema that's going to be present in all forms of lymphedema. Are lymphedema patients that have had microsurgeries candidates for this drug? Yes, absolutely, in principle. Now, if the question is, are you going to be eventually a candidate to use it long-term when it's commercially available? I imagine, yes, absolutely. We have the capacity to enroll patients in our current clinical trial who have had microsurgery, provided that there is a sufficient time lapse between the microsurgery that presumably has not completely resolved the problem and the patient's enrollment in the trial. How long after treatments are results observed? This is a very interesting question. In my use of ketoprofen in 300 or 400 patients, it has become evident that it takes 4 to 6 months before we see the clinical response. This isn't like taking Tylenol for your headache and an hour later you feel better. What we are doing with this drug therapy is actually reversing molecular machinery in the body and asking the body to undergo a healing response, and it's time dependent. And in the patient that I showed you from the Ultra trial, and I show her because she's a very dramatic example of many of the things that we've seen more generally in these trials. When we saw her 5 months into drug therapy, we didn't see anything. And at 6 months, at the conclusion of the trial, she came back and her lymphedema was basically gone. So that's an example of what can happen with drug therapy. We need very much for patients to understand that patience and trust and belief are necessary to reap the benefits of this drug intervention. And it is the reason, therefore, you'll understand that our trial is designed to be a 6-month enrollment, because we need enough exposure to the new drug to be able to say that it does or doesn't work. Let's see. I have a question from one of my colleagues to ask if long-term maintenance therapy with this drug is necessary. I don't know the full answer to that question. Based on patient X that I showed you, you would say the answer is no. Once you achieve a sufficient vascular healing response, you can withdraw the drug and the patient remains well. In my clinical utilization of the drug through research and subsequent open label use in those patients, I've seen two patterns. I've seen a pattern in which we do withdraw the drug after time and the patient maintains benefit. I've also seen patterns where the lymphedema reverts when the drug is withdrawn. So we have a lot to learn about how long to use it or whether there will be a maintenance phase that's required. We have a lot to learn about disease prevention as well. So somebody asked about montelukast, which was not different than placebo. The answer is montelukast blocks LTC4. That's one of the reasons that we were able to conclude from a variety of the observations that is LTB4 and not LTC4 or LTA4 that is driving the disease. 5-LO generates increased levels of all of those compounds because, again, it's at the base of the tree, and you have one branch that goes A, one branch that goes B, one branch that goes C. We are convinced that it is LTB4 that is driving lymphedema, and therefore, we are going to be studying an LTB4 specific antagonist. Montelukast can be taken with impunity in patients with lymphedema. It's just not going to have a positive or negative effect. It's going to have an effect for the disease process for which it's taken, which is typically airway disease, because that's where LTC4 is active. With that, I'm afraid I've come to the end of my time. I want to thank all of you for attending, and thank you for your very insightful questions. I'm sorry I wasn't able to get to all of them. As you can imagine, there's still about 100 left that I won't be able to answer directly, but hopefully you've gotten some information from this webinar. For those of you that are interested in the specifics of the upcoming trial and what it means to be in a clinical trial and what would be required for this specific clinical trial, we'll be back here in 2 weeks. Again, I want to say, for everyone who is not a direct candidate or subject for that specific trial, we're trying to find an answer for all of you, but we have to start somewhere, and we want to start where we can have the most impact on the patient population in the shortest amount of time. So thank you very much for attending, and hopefully I'll see many of you in 2 weeks. Thank you very much. Bye-bye.